Hey everyone, welcome back to Dietitians and Nutrition Support. Today we're continuing on our electrolyte series talking about potassium. Potassium is the major intracellular cation, meaning it's found primarily within the cell. About 98% of our body's potassium is seen intracellularly. Primarily, potassium functions include cell metabolism, maintaining cell growth and volume, enzyme function, protein synthesis, and it's also a crucial part of resting membrane potential for both neural and muscular function. Typically, potassium in the body is regulated through the kidneys, but we also see some loss through the GI tract as well as through sweat. And total potassium in the body is proportional to muscle mass. So you'll see females or older individuals or other individuals that have had some kind of muscular loss having kind of a lower overall potassium quantity in their body. So let's get to talking a little more about what hyper and hypokalemia or high or low blood potassium looks like and how we might manage that in our patients.
So before we start talking about any irregularities in potassium values, we need to know the goal range. So if you're doing a typical blood potassium level, you are probably going to be seeking a goal range of 3.5 to 5.0 milliequivalents per liter. This value can differ depending on the reference range for your particular institution, so just double check with what their guidelines are, but for the most part, you're probably going to see somewhere between the 3.5 to 5. On the left side of our screen, you'll see the term hyperkalemia, which is the term used to identify individuals with excessive blood potassium. So this is folks that are anywhere beyond our 5.0 milliequivalents per liter. But you'll see that there are kind of a gradient of outcomes that you can have with hyperkalemia. So there can be folks that have kind of just this mild hyperkalemia that are just barely above the 5.0, and you can see folks all the way up into the kind of 6.0 to 6.5 milliequivalents per liter and higher. And those individuals are kind of our more severe folks with hyperkalemia. So if we're looking down at the 5.0 level, we might see some weakness, some nausea, some more mild signs. But if you get up into the 6.0 to 6.5 range, this is severe hyperkalemia. So this is individuals that are not only seeing weakness and discomfort, but they're going to be having the potential for respiratory failure, potentially ascending paralysis, and certainly some changes in their electrocardiogram. So these individuals are at risk for cardiac arrest and need very immediate management of their hyperkalemia. When we're looking at the etiology of our hyperkalemia, we're going to see a few different places that this can happen. So of course, when we start to talk about the management of hyperkalemia, we need to identify the etiology first. Looking at the etiology or the source of the problem, we can then actually try and fix the source as opposed to just band-aiding the issue. Our first potential etiology for hyperkalemia is renal insufficiency. So if we're considering the kidneys are our primary source of clearing potassium from the system. So if you have low clearance, then you can have this buildup of potassium in the blood, and that of course can lead to elevated potassium levels. We also see considerations for hyperkalemia taking place with renal tubular acidosis. We can also see instances of impaired potassium loss, and sometimes that can be from medications that are chosen or in general from a reduced GFR. Our second etiology to consider is excess intake. This can be individuals who have a lot of supplement intake, or just in general have another instance in which they have maybe difficulty clearing potassium and need to just be mindful of the intake that they have. So sometimes excess intake can be its own etiology, or sometimes it can kind of compile with other etiologies as well. Our third etiology to consider is hemolysis. So if we consider that potassium is typically an intracellular electrolyte. If it's inside the cell and you see some cell bursting or cell lysing, you may see instances of increased potassium availability in the bloodstream, right? So if we crush the cells that have a lot of potassium, the potassium can get into the bloodstream. So instances of hemolysis that you might see are GI bleeding, if there are any kinds of crush injuries, so this can release excess potassium, and just general instances in which you might see potassium bursting from cells. Kind of jumping back to this idea of impaired potassium loss, we do see instances with medications that are of particular concern. So these medications are going to be potassium sparing meds. So that can be types of diuretics, as well as ACE inhibitors. So definitely being mindful of whether or not an individual is on some kind of medication that could be leading to inability to release potassium adequately. We can see individuals that have a transcellular shift. That can happen in cases of metabolic acidosis or DKA or diabetic ketoacidosis. And finally, not necessarily hyperkalemia from the patient itself, but we can see something called pseudo hyperkalemia. And this can show up when there are issues with lab specimens. So if the specimen undergoes that hemolysis, so again, that kind of extra release of potassium that was not anticipated. This can happen in times of excess platelets, as well as white blood cells. And you can also see this with improper blood draws. So obviously, as you can tell, there are a ton of different etiologies that can lead to hyperkalemia. So again, keeping in mind the etiology for your hyperkalemia can help to inform the treatment or the management option that might work best for the patient. So there's a few different options we can choose here for treatment or management. The first thing that you might consider would be, of course, removal of potassium from any IVs, as well as other exogenous sources. So if the person is over supplementing or eating a bunch of potatoes, right, something that's causing exogenous gain, we want to try and reduce that as much as possible. Secondly, we want to discontinue all potassium sparing medications. So if they are on some kind of diuretic, something to that extent that is sparing potassium, we actually may consider moving them to something like a potassium wasting diuretic so that they can help to clear some of that potassium and not see the excess buildup. You can also use potassium exchange resins. These can be particularly helpful for increasing fecal loss of potassium. If you're having issues with that transcellular shifting, you may want to try promoting intracellular shifting. And this can be done with either dextrose or glucose, as well as insulin. And finally, for appropriate individuals, we can choose to use dialysis, which can help to increase the amount of potassium that we pull out when we're dialyzing the individual to get that hyperkalemia down. For instances of life-threatening hyperkalemia, you may see the use of calcium salts, as well as hypertonic sodium solutions.
Neither of these actually lower potassium levels, but they will serve to protect myocardial function from the potential damaging effects of hyperkalemia. Also note that it's only good to use hypertonic sodium solutions if you have cases of low sodium and high potassium.
So if we jump to the right side of our screen, we can start our discussion on hypokalemia. So this is the low blood potassium ranges. So this is folks below 3.5 milliequivalents per liter. And these folks we could also consider on a gradient. So sometimes when you're closer to the 3.5, that's considered that mild hypokalemia. In many cases, this can be asymptomatic. And as people start to get even lower with their potassium status, we can see the more severe hypokalemia definitely within folks below 2.5 milliequivalents per liter. This severe level can present as nausea and emesis as well as other GI issues, and you may see instances of weakness, neuromuscular changes, respiratory failure, and arrhythmias. So definitely need to be just as equivalently concerned about severe hypokalemia as we were about severe hyperkalemia. So being aware that this person's going to need some significant help with finding corrections to get that potassium level up. So again, similarly to hyperkalemia, we of course want to keep the etiology of the hypokalemia our focus. So we want to know why this person has a potassium deficiency, and if possible, we want to help manage that primary etiology. So the first etiology that we might see hypokalemia take place in is a redistribution or shifting of potassium, typically going from the plasma into the cell. So with this redistribution, we're seeing the potassium move from the plasma into the cells. And this can, of course, decrease the serum value. That is, of course, what we read. And this happens with times of insulin administration, potentially in refeeding syndrome, anabolism, and alkalosis. So times in which the cell might need additional potassium, the plasma kind of sacrifices that potassium and allows for the potassium to get taken into the cell or redistributed there. So while this can be potentially beneficial for the cell in some cases, this leads to just a total plummeting of our plasma level. And so we need to be able to correct that because we still need potassium in our plasma, even though it's technically mostly an intracellular electrolyte. Our second primary cause is going to be extra renal losses. So things outside the kidney. We can see instances of hypokalemia and extrarenal losses in times of diarrhea, laxative abuse, fasting, inadequate intake, as well as magnesium depletion. So in all of these instances, we have excessive loss or we don't have adequate amounts available to us to maintain the typical potassium status. So our final etiology for hypokalemia is going to be renal-based losses. So this can be instances of excessive diuresing. So if you have potassium wasting diuretics, you can see excessive loss of potassium. And you can also see instances of excessive mineralocorticoid usage that can lead to this renal-based loss. You also will see some instances of individuals with renal tubular acidosis that can have instances of hypokalemia as well. So when selecting a treatment or a management plan, keep in mind that primary etiology and then try and focus towards not only managing the hypokalemia, but targeting that etiology. For individuals who have either enteral nutrition or oral access available for them, we want to choose oral supplementation as much as possible for our kind of first line. Potassium is really well absorbed in the GI tract, so it's good for individuals who have mild hypokalemia to be able to replete that potassium status. Typically, this can be done with KCl tablets or capsules and potentially even liquid for repletion, but other salts can be used. If you have someone who has acidosis, you may choose to use a potassium bicarb instead to try and help manage that acidosis as well. And if you have someone who has some potential hypophosphatemia as well, maybe someone with refeeding, you may choose to do a KPhos instead to kind of do two birds, one stone there. So for individuals that oral is not an option, you can choose to use parenteral. And if you're using parenteral, that could probably be for someone with moderate to severe hypokalemia, potentially symptomatic hypokalemia, and you're going to want to use probably something with either like a chloride, an acetate, or a phosphate salt within your parenteral nutrition. So note that when you're doing any kind of parenteral potassium administration, potassium can be pretty irritating to the veins. So pretty much a max value for infusion is going to be about 80 milliequivalents per liter for peripheral administration. But really, infusions should probably be about 30 to 40 milliequivalents per liter, unless there's really severe hypokalemia present. If you're looking at a central line, you can go upwards of 120 milliequivalents per liter. So a little more flexibility on administration with a central line. Now, kind of just from an overarching standpoint, really infusions should target going about 10 to 20 milliequivalents per hour. So from a time frame per hour, 10 to 20. And then in total, we're looking at no more than 200 milliequivalents per day. So again, keeping in track that peripheral is going to have some limitations per liter just to reduce the vein irritation. Central has a little bit higher opportunity for potassium administration there, but overall you really don't want to exceed these values for each hour and overall for the whole day. Finally, if there's some other etiologies that are leading to this hypokalemia, you of course want to manage those etiologies. So if you have some medications that are leading to hypokalemia, you obviously want to minimize those meds. So that could be moving away from things like sorbitol or any potassium wasting diuretics. If there are other issues such as refeeding syndrome, obviously managing that refeeding syndrome, managing any acid-base problems. If there's a magnesium deficiency, managing that. And then if it's an instance of reduced intake in general, helping to increase intake and availability of potassium. So let's jump back over to our other screen and talk about some last tips for potassium management.
All right, so just a few other tips about potassium here. Potassium is available as a salt when you're putting it into a TPN or a rider. It comes in a lot of different forms, so you may see potassium citrate, potassium bicarb, potassium chloride is probably the most popular, potassium phosphate, so lots of different options. And sometimes it can be most beneficial to identify the etiology of the hypokalemia or the potassium deficiency when you're selecting which kind of salt you're going to replete with. So that being said, regardless of the salt that you choose, you do want to be mindful of the rate that you replete at. So similar to what we talked about with sodium, making sure to reintroduce potassium slowly can help to avoid the risk of overcorrection, which is sometimes easy to do with potassium. So we want to avoid hyperkalemia that can come from overcorrection or excess supplementation. So just making sure to be cautious, especially in states of renal insufficiency or failure, are at higher risk for excessive repletion. So really you don't want to exceed about 200 milliequivalents per day. That's kind of the cutoff point for repleting potassium. Also, something to keep in mind is that you sometimes will have patients who it's appropriate to put the potassium directly into the TPN bag, maybe someone with some mild hypokalemia, so it's okay for them to get their potassium supplementation over the 24-hour period that they'll have the TPN bag running for. Or if you have someone with maybe more moderate to severe hypokalemia, it could be more beneficial for them to get a rider of the potassium to get it to them sooner and better correct that hypokalemia in a fashion that's most appropriate for them. So many different options with potassium repletion, but just keeping in mind what kind of salt, how fast you're trying to replete, making sure it's appropriate, and then also choosing the best modality for that repletion. So hopefully this video has been helpful for you to learn a little bit more about potassium and what we might do in times of hyper or hypokalemia. We hope that the entire electrolyte series has been going well for you. And if you have any comments or questions, please feel free to leave in the boxes below, and we'll see you next time.